Thank you for joining cureCADASIL Association's third webinar in our CADASIL Connection speaker series. I'm Jane Gunther, and I will be your moderator. Today's feature presentation is entitled The Misdiagnosis of CADASIL, presented by Dr. Jorge Ortiz Garcia from the University of Chicago Medical Center. We will start today with an introduction to the cureCADASIL Association's Family Registry, presented by Sandra Talbert. Before we begin, I would like to go over a few housekeeping items. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You were prompted to select your audio, and the default setting is computer audio. If you prefer to join over the phone, which can provide better audio quality, select telephone in the audio pane, and the dial-in information will be displayed. You have all joined this webinar in listen-only mode. All callers are automatically muted. At the end of the presentation, Dr. Ortiz Garcia will answer questions that were pre-submitted during the webinar registration process. However, at any time during the webinar, we invite you to type questions in the question pane of the control panel. These questions will be forwarded to either of our two panelists following the webinar, and even though these questions will not be answered today, it is of value to know the types of questions the CADASIL community has about their disease and the patient registry. Today's presentation is being recorded and will be available on the cureCADASIL Association website. In addition, we have 3 handouts to share. In your control panel, you will see a handouts pane and 3 documents listed that you can download. The devastation that CADASIL has on families led a group of volunteers in 2012 to establish the cureCADASIL Association, whose mission encompasses patient advocacy, education, and research support. The dedication and passion of these volunteers to cureCADASIL has led to a number of successes by our association, and one of these successes was in 2015 when cureCADASIL established a family registry. Sandra Talbert, trustee on the board of cureCADASIL Association and creator of the cureCADASIL Patient Registry, will present a short overview that will answer a number of frequently asked questions about the registry. The registry is one way that families can participate in increasing our understanding of the disease and support therapeutic and biomarker development. Following the patient registry presentation, Dr. Jorge Ortiz Garcia will present an informative background on CADASIL from the clinical perspective and one institution's experience in diagnosing CADASIL. Sandra Talbert has a Master's of Science in Public Health from the University of North Carolina. She is a Senior Director in Health Economics at RTI Health Solutions, a respected health economics research and consulting organization. During her 10 years at RTI, Sandra has published in the health outcomes field on cost effectiveness models, budget impact models, and burden of illness studies. Sandra has been an active member of cureCADASIL Association since 2014 and a volunteer trustee since 2016. One of the several projects she has initiated for cureCADASIL is our family registry, which she oversees as the registry coordinator. If you have any questions about our registry, Sandra is the one to ask. I welcome Sandra to provide us with an introduction to the registry.
Great, thank you, Jane. We thought we would take the opportunity today, prior to Dr. Ortiz Garcia's presentation on the misdiagnosis of CADASIL, to share the cureCADASIL Family Registry, which includes patients who are diagnosed with CADASIL. I'll present an overview of registries in general, what they are and why they are important, and then specifics on the cureCADASIL Family Registry, and how having data from patients diagnosed with CADASIL can help inform many things around misdiagnosis, such as reasons why patients are misdiagnosed, what they are typically misdiagnosed with, such as multiple sclerosis or Parkinson's disease, and commonalities between patients that could be used to screen people likely to have CADASIL and thus avoid misdiagnosis. So first, for an overview, what is a registry? The National Committee on Vital and Health Statistics describes registries broadly. A registry is an organized system for the collection, storage, retrieval, and analysis of data. The type of data then varies, as there are many types of registries that I've listed here on the slide. Disease registries often follow people with a certain disease and can have multiple objectives. For example, a population-based disease registry may try to estimate the types of treatment different people have and receive in one part of the country versus a different part of the country, or try to understand the natural history of a disease by capturing important clinical outcomes over time. A registry for a rare disease like CADASIL may just be a contact registry for patients with the disease to be informed when there's a study that they may be eligible to join. Or a registry can include contact data as well as clinical data to get an understanding of the type of care patients receive or how their symptoms change over time. Data can be provided by patients, or it could be provided by physicians, or both. Registries can also be very broad or specific. So for example, someone with CADASIL could join both a neurological registry and they could also join a CADASIL specific registry. Some registries can be short in duration. For example, there are vaccine registries that monitor the safety of people receiving vaccines, or a pregnancy registry that ends once the pregnancy ends. And other registries follow patients over a long period of time. Patient registries often have different individual objectives. The names here are just an example of the many used in an attempt to best describe the reason for the registry. Many people often ask why registries matter. Registries are important because they can benefit rare diseases and rare disease patients in many ways. First, they can improve patient care. When patients join a registry and complete surveys that collect the same information across patients, oftentimes this leads to information discovery. All of a sudden, you have more than anecdotal evidence that everyone you know with CADASIL has low blood pressure, or everyone in your family has vertigo. This can give researchers a reason to expand research beyond the few case studies that have been done around, for example, low nocturnal blood pressure in CADASIL patients. Or it can incentivize a larger study around the symptoms to determine whether doctors should check for this. And then this in turn leads to improved patient care. Second, registries can help patients be heard, which can be even more important for rare disease patients, since many times your doctors only have 1 to 2 other CADASIL patients. Registries can have short surveys that let you share your point of view on which symptoms are most important symptoms to find treatments for, or which existing treatments you wish there was better information on. Third, accelerate research. So this is a coined term that you might often hear. I know I hear it a lot, but it is for a reason. My colleague Jane, who hosts the CADASIL Connection webinars, can attest from her work in drug development that drug development is hard, time-consuming, competitive, and very, very expensive. When a drug company learns that a rare disease community has a rare disease registry with useful data, the company sees a lot of potential savings in their time, but also their resources, which can then make the company more likely to pursue drug development. There are more than 7,000 rare diseases, and so drug development for rare diseases can be very competitive. Giving pharma companies and drug developers a reason to choose CADASIL to spend their time, money, and research and interest on is critical. Okay, so moving now to the cureCADASIL Family Registry. Our registry was launched in August 2015 and had about 100 participants join in 2015. It then grew to approximately 200 participants in 2016, and now we're at approximately 230 participants. The cureCADASIL Family Registry is a disease-specific and patient-reported registry. So it includes surveys completed by patients, and it is not linked to medical records or physician-reported data. It collects anonymous personal data such as your age or your gender, as well as medical information you choose to report, and genetic information can be uploaded by you as well. It is longitudinal, which means that it follows patients over time by allowing participants to complete the surveys and then update them periodically. The cureCADASIL Family Registry is an online registry that's hosted through our partner organization, AltaVoice, that we partnered with because of their experience with over 40 registries for other rare diseases. and they have since been acquired by the diagnostic company Invitae. In the registry, there are currently 4 patient surveys or questionnaires that participants will complete at their own pace. The cureCADASIL Family Registry is also a global registry open to anyone, and we currently have people from over 15 countries who have joined. Many of you who have joined the registry may be familiar with seeing the map of the number of patients in the registry. This graphic and other graphics on high-level data are available to patients who join the registry, complete the surveys, and choose to share their data. Those who share their data can then view the data of others who have chosen to share, such like other social media websites. For example, you can see things such as age of diagnosis or the % of patients taking medications that they choose to share or list, such as low-dose aspirin or L-arginine. People with a CADASIL diagnosis can join the registry, as well as those with a family member, those with a family history of CADASIL, but who are undiagnosed. So when we designed the registry, we felt strongly that it was important to not only include people currently diagnosed with CADASIL, but because of the high level of undiagnosed patients and misdiagnosed patients, we thought it was important to also have family members who are at direct risk of CADASIL. So, for example, if you're diagnosed, but one of your parents, brothers, sisters, cousins, or children are not diagnosed, they can join the registry. This is important for research because we all have family members who are not diagnosed for various reasons, either because they've chosen not to be diagnosed, the cost of the genetic test has kept them from being diagnosed, or they don't feel it is needed because there isn't yet a treatment for CADASIL. But one day there will be a treatment for CADASIL, and if there's 10 years of good data on someone who didn't want to get diagnosed and then 10 years later decides to get diagnosed, that's really important for a rare disease like CADASIL that has so few patients and so little data. Since the registry launched 2 years ago, surveys have now been expanded to be available in both Spanish and Portuguese. They were originally in English, and there's a Google Translate function, but having the surveys in Spanish and Portuguese is a new addition. We also had a few dedicated volunteers help in 2017 with distributing materials on CADASIL and the registry to physicians throughout the U.S. to give to their patients. We're always looking for volunteers interested in helping us grow outreach to doctors to get materials on CADASIL and the cureCADASIL Family Registry to not only doctors' current patients, but also to newly diagnosed patients. I know this would be impactful for many people. Being diagnosed can be a difficult time, especially for rare diseases like CADASIL, where there's no known treatment. Equipping physicians with materials to provide to their patients about CADASIL, about all of our online support groups, and the cureCADASIL Family Registry is a way to make the diagnosis process and journey a bit easier. Let's see. Here I'm listing a few frequently asked questions that we often receive. A lot of people ask, once I join, will I be contacted for studies? And the answer is, if you choose to be. This is one of the questions you will answer. You can actually participate. A lot of people also say, I'm already in a registry, so I'm already participating. Can I join another registry? And you can actually participate in multiple registries. As I explained earlier, different registries may have different objectives. Once you join, it's also important to update your data over time. And a lot of people say, no one else in my family has CADASIL, and so they wonder if they can participate. And so yes, anyone related to you by blood, so an uncle, a cousin, or a sibling can participate as an at-risk individual if they would like. Here's a screenshot of the login page to the cureCADASIL Family Registry. Each participant has their own individual login to the registry where they can access and update their data and see the data from others in the community. So looping back as to why a registry for CADASIL is important. In general, it's important for many of the same reasons I already presented on why patient registries are important: for research, for improved medical care, and for patients sharing knowledge with each other. But I would argue registries are even more important for rare diseases for 2 reasons. First, because with rare diseases, there's often a feeling of isolation when you are diagnosed because you don't know others with the disease. So being able to collect and share information with other patients and caregivers, as well as the medical and research community at the same time, is an incentive that other registries, maybe on diabetes, don't have, or at least they have to a lesser extent. This is why I think the support groups on Facebook are so popular for CADASIL as well as other rare diseases. People want to know what symptoms others with CADASIL have or how they are managing their disease. And two, because many of the 7,000 rare diseases are difficult to research because they lack a diagnosis code. Only 10% of all rare diseases have an ICD-10 code used by your doctor when you go to a doctor visit. CADASIL is, unfortunately, one of those many rare diseases with no ICD-10 code. The problem here is many research studies that are conducted on the incidence of CADASIL, which is still unknown in the U.S., diagnosis rate and cost of CADASIL are conducted using these databases of insurance claims that identify people with diagnosis codes. So without a diagnosis code for CADASIL, these studies simply can't be conducted. So registries become even more important for rare diseases, particularly those like CADASIL with no ICD-10 code, because they are often the only source of medical information where you can be certain the data you're looking at are for people with the condition. This final slide shows many potential ways that cureCADASIL has identified to expand the cureCADASIL family registry if we had unlimited time and, of course, unlimited money. The listing on the slide are just some examples. Actually, many of these potential areas for growth require small financial investment and could greatly improve the strength of the registry, either through better quality data, more specific health outcomes that are known to be clinically meaningful to patients, or more registry participants. These are all things that lead to more robust data that researchers really need. So sort of a good bang for our buck in terms of how cureCADASIL could expand the registry data with the biggest payoff in terms of what researchers need. As with any patient-driven research, feedback from CADASIL families is important in order to understand what aspects of the disease are most important to you. This is known as what is clinically meaningful, or what impacts how you feel, your quality of life, or your disease progression. This could be the fact that you have a migraine once per month that debilitates you, or the age when you started requiring an assistive device like a walker, or that a large proportion of patients experience vertigo early in life, or many patients have dysphagia, or trouble swallowing later in life. These are examples of anecdotal evidence you see posted on social media all of the time, and it isn't being captured or shared with researchers and physicians or the medical community at large. As cureCADASIL explores ways to expand the cureCADASIL family registry, interested volunteers are always appreciated, and feedback from CADASIL patients and family, I can't emphasize enough, really is critical. We can't grow in all areas at once, but we can be smart about the way we grow, and the best way to do that is to hear from all of you on the line today, from patients and families directly, as well as physicians.
Thank you, Sandra, for this informative overview, not only of cureCADASIL registry, but of registries in general. Thank you for increasing our knowledge. Our featured speaker is Dr. Jorge Ortiz Garcia. Dr. Ortiz Garcia attended the Universidad Católica de Santiago de Guayaquil in Ecuador, receiving his medical degree in 2006. In 2013, he completed an internship in the Department of Internal Medicine at Loyola University Medical Center in Chicago. He continued at Loyola University Medical Center training under Dr. Jose Biller with a residency in the Department of Neurology, followed by a fellowship in vascular neurology. Dr. Biller has followed several CADASIL patients since 2008, and it is through this work that Dr. Ortiz Garcia developed his interest and experience in working with CADASIL patients. In July of this year, Dr. Ortiz Garcia began his neurocritical care fellowship at the University of Chicago Medical Center, where he plans to continue to see CADASIL patients. Active in the stroke community, this year, Dr. Ortiz Garcia received a scholarship to attend the American Heart Association and American Stroke Association Fellows in Training workshop. Dr. Ortiz Garcia and his colleagues were awarded a Safety and Quality National Award by the American Academy of Neurology at their 2017 annual meeting for their project entitled Simulation-Based Training in Brain Death Determination, Incorporating Family Discussion. He is a co-author of a poster presented at the 2017 annual meeting of the American Academy of Neurology entitled Misdiagnosis of CADASIL, One Institution's Experience. Dr. Ortiz Garcia will be sharing today an informative background on the clinical aspects of CADASIL and the diagnosis of CADASIL. Welcome, Dr. Ortiz Garcia.
Hello everyone, and welcome to the webinar series again. Thanks to the cureCADASIL Association for inviting me to present our work in the webinar series. As you already mentioned, we are going to talk about the misdiagnosis of CADASIL based on our research study done at Loyola University of Chicago. So before to start, I want to say thanks to the co-authors in this study. First of all, Dr. Jose Viller, who is my mentor. He's the principal investigator in our research and the chairman of the Department of Neurology at Loyola University. I want to say thanks to Dr. Karen Orjuela, who was a vascular neurology fellow at Loyola University, and now she's an assistant professor faculty at University of Colorado. Thanks to Dr. Rochelle Swice, who was faculty at Loyola University. Now she's a part of the Department of Neurocritical Care at Advocate Christ Medical Center in the Chicago area. So for today, I don't have nothing to disclose for our presentation. Let's review the outline for today. We are going to do an overview. We'll review the epidemiology, molecular and genetics, clinical manifestations, natural history, imaging findings, differential diagnosis of CADASIL. We'll talk about our experience at Loyola University. We'll talk about the diagnostic test management, and at the end of our presentation, we have a stay-home message. So the acronym CADASIL means cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Reviewing the literature, we found that in 1955, Van Boger described an entity called subcortical encephalopathy of Bies-Wander type of rapid course. It's also known as hereditary multi-infarct dementia, chronic familial vascular encephalopathy, and familial subcortical dementia. In 1976, Mary Bissier described a 50-year-old man with a lacunar infarct, extensive leukoencephalopathy, and a strong family history. In collaboration with Elizabeth Turner, both of them studied 57 adults of the family. In 1993, they mapped the mutated gene onto the chromosome 19, and 3 years later, they identified the gene as Notch3. They named the condition CADASIL, which has subsequently been identified in hundreds of families worldwide. Going to the epidemiology, the prevalence of CADASIL is estimated in 1.98 per 100,000 people around the world. The prevalence 4.14 per 100,000 people is one were to consider predicted carriers of the mutation. The actual prevalence could be much higher because sporadic cases can occur. CADASIL has been reported to account for the 2% of cases of lacunar stroke with leukorrhiosis in patients younger than 60 years of age, and for 11% of cases in those younger than 50 years of age. Multiple small and national registries have estimated the minimum prevalence that we have nowadays. There are more than 170 mutations in the Notch3 gene with the varying worldwide distribution. The mutations include single missense mutation, small infrate deletions, and splice site mutation. CADASIL is the most common Mendelian form of small vessel disease causing hereditary subcortical dementia, and is the most common monogenic arteriopathy of the small vessels in the central nervous system. More than 600 families have been described worldwide. CADASIL has an insidious onset, and the medical recognition have increased in the last few years. The mean age of onset of symptoms is around 45 years of age. European, American, Asiatic, African pedigrees are found in the medical literature with CADASIL. CADASIL is an autosomal dominant disease caused by the mutation in the Notch3 gene. This gene encodes a single-pass transmembrane receptor of more than 2,300 amino acids with an extracellular domain containing the 34 epidermal growth factor repeats. Each include 6 cysteine received, 3 Notch link 12 repeats, and a single transmembrane domain and an intracellular domain. In this graphic, we can see the Notch3 gene and the exons that we found inside. Notch3 has more than 33 exons, but the mutations occur in the exon 2 to 24. More than 40% of the mutations in more than 70% of the family occur in those exons. 150 mutations have been reported in at least 500 pedigrees nowadays. Over 90% of the mutations are missense mutations. Others are small in-frame deletions or splice site mutations, and the novel mutation has also been reported. The Notch3 gene also accounts critical for vascular smooth muscle cell differentiation and vascular development, lends the structural stability of the vascular smooth muscle cell, and encodes cytoplasmic membrane receptors involved in the cellular differentiation and cell cycle regulation. Moving into the clinical manifestations, CADASIL include migraine with aura, transient ischemic attack, TIA, recurrent subcortical ischemic stroke, dementia, mood disturbances, and other miscellaneous manifestations. The migraine with aura is the earliest manifestation in women compared to men. The stroke and TIAs account for 75% of lacunar syndromes. Parenchymal brain hemorrhage relatively are uncommon in the clinical manifestations. Mood disturbance account for depression, apathy, manic episodes, and dementia is often associated with upper motor neuron signs, pseudobulbar affect, gait impairment, and or urinary incontinence. Focal or generalized seizures are also being described. Women are more likely to present with migraine with aura, and men are more likely to present with acute stroke. In this slide, we have the natural history of the main clinical manifestation of CADASIL. You can see in the blue arrow on the bottom of the slide the years of age, and you can see the abnormalities that present. The exact age of earliest onset of the manifestation of the first MRI abnormalities are uncertain. The frequency of the T2 white matter abnormalities increase progressively and becomes constant by around 35 years in all patients. The onset of migraine is estimated around 20 years of age until the age of 50. Then the onset of recurrent ischemic stroke, subcortical stroke presenting like lacunar syndrome at the age of 35. And then later at the age of 45, 50, start the mood disturbance, apathy, motor disability, all combined with the executive dysfunction, and at the end of the disease, patients present with dementia. As I mentioned, migraine is the earliest feature of the disease in 75% of the cases. The pattern of migraine differs from that seen in the general population, with a predominance of migraine with aura and frequent report of complicated and prolonged aura. Atypical auras, such as prolonged visual auras manifested with fortification phenomenon on escotomas, gastrointestinal manifestations, dysarthria, confusion, focal neurological deficit, are other uncommon manifestations, and they are experienced by 60% of the individuals with migraine with aura in the CADASIL population. Other manifestations are aura without headaches, hemiplegic auras, and basilar type migraine. The pathophysiological reasons leading to the increased aura prevalence in CADASIL are unknown. A possible mechanism is an increased susceptibility to the cortical spreading depression. It's also possible that the migraines in CADASIL involve the brainstem region. And alternatively, the Notch3 mutation itself may act as a migraine or a susceptibility gene. Going to the ischemic stroke, so those strokes present like a recurrent subcortical ischemic stroke. The mean age of onset is age of 40, plus minus 9 years of age. Typical presentations are lacunar syndromes, like a pure motor hemiparesis, pure sensory syndrome, dysarthria clumsy hand syndrome, ataxia hemiparesis, and sensory motor syndromes. Also, the patient can experience vascular Parkinsonism and pseudobulbar states. The large artery territorial infarcts are rare in CADASIL. Hypertension and past years of cigarette smoking are associated with increased risk of stroke. The history of stroke is a major risk for both dementia and disability. And the burden of lacunar lesions correlate with the disability and cognitive impairment. Going to the cognitive impairment, so the early impairment is affect the executive function, and probably due to dysfunction of the subcortical frontal network. The greatest cholinergic loss in the posterior parietal, dorsal frontal, and occipital cortices due to the cholinergic neuronal impairment are seen in those populations on CADASIL. There are a normal density of cholinergic axons in the hippocampus, entorhinal cortex, and the temporal neocortex. With the time, decline in attention and memory is seen in these patients, and with relatively preservation of encoding process and episodic memory. Impairment of multiple cognitive domains in late stage of the disease are seen. In the picture below, in the panel A on the left, these are intraparietal sulcus in a 55-year-old control specimen. The tissue the single arrow show that or point cholinergic fibers coming from the nucleus basalis. In the panel B to the right is the same region of the brain in the 36-year-old CADASIL patient. The single arrows point the cholinergic axons and the double arrow the cholinergic neurons. So the density of the cholinergic axons is very much diminished in CADASIL, and that's the cause of the cognitive impairment in those patients. Dementia present with a vascular dementia in midlife, predominantly frontal lobe dysfunction, executive dysfunction, due to the neuronal cortical apoptosis. Severe mood disturbance include depression, mania, psychosis, paranoia, schizophrenia, dysthymia, and emotional lability. Other manifestations on CADASIL include the epileptic seizures, CADASIL coma, lobar hemorrhage, and retinal abnormalities. Epileptic seizures rarely are the early symptoms. Patients experience 2 to 10% of the cases start with epileptic seizures. They can be focal or generalized, and the seizures are related to the white matter lesions near to the cortex, and rarely those patients experience status epilepticus. Talking about CADASIL coma, it's an acute self-limited encephalopathy that may be recurrent. The cardinal features include confusion, headaches, seizures, and pyrexia. It's often misdiagnosed as acute encephalitis. Patients experience full recovery in a period of 7 to 14 days. The mechanism underlying for the CADASIL coma is unknown, but the remarkable similarities to some features of the calcium channel gene mutations make some indirect channel disorders seem likely and raise the possibility that acetazolamide may be the possible treatment for those cases. Talking about cerebral hemorrhage, this entity is rare in patients with CADASIL. Patients can have cerebral microbleeds, and the ICH, the intracerebral hemorrhage, develop closely related to the number of microbleeds. Blood pressure and glucose control play an important role in those patients. And you can see in this study that the blood pressure and hemoglobin A1C independently predict cerebral microbleeds in CADASIL. Patients with a high blood pressure and diabetes are more likely to have cerebral microbleeds in CADASIL, and those may favor the rupture of the vascular wall and promote the occurrence of cerebral microbleeds in different locations complicated with lobar hemorrhage. And you can see in the table, the O-value is at 4.9 for the hypertension and 3.25 in patients with an increased hemoglobin A1C. Talking about retinal abnormalities, those include arteriovenous nicking, 90% of the cases, arterial narrowing, 80% of the cases, bilateral peripapillary arteriolar shelving, 30%. No retinal infarctions, vascular occlusions, exudates, or hypoperfusion of affected vessels has been seen on those patients. Miscellaneous manifestations include rare cases of deafness, rare involvement of the large vessels. There is no cranial nerve pulses, there is no spinal cord involvement, and there is no muscular manifestations in patients with CADASIL. The imaging findings, we are going to exclusively talk about the brain MRI findings, and those include widespread T2 weight and flared white matter non-enhancing hyperintensities involving the periventricular white matter, the centrum semiovale, the thalamus, and the basal ganglia. The anterior pole of the temporal lobes, the involvement of the temporal lobes is seen in 70 to 80% of the patients with CADASIL, and the extreme and external capsule, brainstem, and the corpus callosum also can be involved. You can see lacunar infarcts and widening of the virtual Robin space or perivascular space. Microbleeds in 30 to 50% of the patients, and those abnormalities may be detected in pre-symptomatic phase. In the next slide, I have a brain MRI in the flare sequence. On the left, on the yellow, with the yellow arrow, you can see the involvement of the temporal pole. On the photo on the right side, on the yellow arrow point, the involvement of the centrum semiovale, involvement of the external and extreme capsule, and involvement of the centrum semiovale and the posterior aspect. We have periventricular white matter changes, and you can see recurring ischemic subcortical infarcts on those patients. Regarding MR angiography findings, those are typically normal. They have normal lumen diameter of the lenticular striate arteries, and rarely there is involvement of the large vessels. Cerebral angiography, the cerebral angiography is not contributory for diagnosis of CADASIL. It is associated with complications in 85% of the cases. Or patients can experience worsening deficit of vasospasm. So our recommendation is that cerebral angiography is contraindicated as may trigger CADASIL-associated coma. In one study that they evaluated 16 patients with CADASIL, that they obtained a cerebral angiography, those patients experienced transient events. 6 of them experienced transient events, 3 of them reversible deficits, and 2 of them permanent deficit. All those deficits include aphasia, blindness, visual impairment, seizures, hemiparesis, sensory deficit, confusion, and 1 case of CADASIL coma. Going to the differential diagnosis, the differential diagnosis for CADASIL is broad. So including Binswanger disease, that is actually a clinical syndrome of vascular dementia with multiple causes, multiple sclerosis, cerebral amyloid angiopathy, cerebral vasculitis, adrenoleukodystrophy, other leukodystrophies, myoclonic epilepsy with lactic acidosis and recurrent stroke. MILAS is a mitochondrial disease. CADASIL, cerebral autosomal recessive arteriopathy with subcortical infarct and leukoencephalopathy, hereditary small vessel disease other than CADASIL, and other leukoencephalopathy of unknown cause. In this table, we summarize other hereditary small vessel disease other than CADASIL, including retinal vasculopathy with cerebral leukodystrophy, hereditary endotheliopathy with retinopathy and nephropathy and stroke, hereditary vascular retinopathy, hereditary systemic angiopathy, hereditary small vessel disease of the brain, and pontic autosomal dominant microangiopathy and leukoencephalopathy. So in our differential, we have to talk about cerebral amyloid angiopathy, and this slide showed a 66-year-old man with multiple lobar hemorrhage secondary to cerebral amyloid angiopathy. Under the spectrum of the small vessel disease, you find white matter changes, periventricular white matter changes, you find hypertensive arteriopathy, and you find cerebral amyloid angiopathy. So in this MRI, you can see the difference when you compare to CADASIL patients. So the white matter changes are, you have periventricular white matter changes, mainly posterior, in the posterior horn of the lateral ventricle. You don't see involvement of the extreme and external capsule, and you don't see the involvement of the temporal pole. Then you have the lobar hemorrhage that is very common in patients with the cerebral amyloid angiopathy. So those patients can many times remain asymptomatic, patients with cerebral amyloid angiopathy, or they can experience lobar hemorrhage, or they can experience transient neurological deficits known as amyloid spells. On other forms of cerebral amyloid angiopathy includes superficial siderosis and the inflammatory variant of cerebral amyloid angiopathy. So talking about metachromatic leukodystrophy in the differential, this is an autosomal recessive lysosomal storage disorder resulting from deficiency of the enzyme adisulfatase A, results in the multi-organ abnormal accumulation of sulfatide, including within the central nervous system, and eventually results in progressive demyelination. Corpus callosum involvement is very common, and frontal, parietal, periventricular, and deep white matter involvement is very common in this disease, with the sparing of the subcortical white matter until late in the disease. Krabbe disease, this is other autosomal recessive disorder due to the absence of the galactoceramide beta-galactosidase, resulting in inappropriate accumulation of toxins, galactose, phenocin. Some, is not most, neurocriological studies in the literature categorize Krabbe disease as early onset, patients younger than 2 years, and late onset, patients older than 2 years, with imaging findings of both juvenile and adult are contained within this group. So predominantly affect the corticospinal tract with the parietal occipital and periventricular white matters and the corpus callosum. And also you'll see symmetric or asymmetric T2 prolongations in the corticospinal tract, finding of the isthmus of the corpus callosum and variable degrees of the posterior white matter volume loss and T2 weighted hyperintensities. Patient with adrenoleukodystrophy is an X-linked white matter disorder due to impaired transport of very long chain fatty acid into peroxisome. May have normal neuroradiologic studies or demyelinization along multiple tracts, including corticospinal tract, spinothalamic, visual and auditory pathway. Male patients may have severe bilateral lobar involvement, and periventricular and deep white matter involvement predominate with eventual subcortical involvement. And you can see frontal and temporal white matter involvement is also possible. So it's mainly posterior, as you can see in the photograph. Alexander disease is a dysfunction of the glial fibrillary acid protein, may present with large areas of T2 prolongation of the supratentorial white matter with frontal lobar predominance. Adult onset, patients typically present with medullary upper cervical cord signal abnormalities and volume loss, as well as dentate signal abnormalities of the spinal cord. Most of the patients demonstrate some abnormal T2 prolongations in either the frontal or the posterior periventricular white matter. You remain keeping your mind, Alexander disease A involves the anterior part of the brain, your frontal lobes bilaterally. So other entity in our differential include virtual Robin space or perivascular space, that is a PL-lined fluid field structure surrounding the penetrating arteries and arterioles along the path of the lenticular striate arteries. Those patients remain asymptomatic. It's smoothly demarcated lesions, iso-intense to the CSF and also pulse sequence without enhancement. So you can see bilateral symmetric involvement of the basal ganglia, subinsular region, and the cerebellum involving the dental nuclei. Patients with migraine also can have white matter changes involving the pons and the subclinical infarctions in the posterior circulations. White matter changes in the deep white matter account for 40%, and the periventricular region account for 19% in T2 weighted and flared image. Multiple sclerosis is the most common misdiagnosis in patients with CADASIL. Axial and sagittal flare sequence remain the main and preferred sequence for evaluation of periventricular and juxtacortical lesions. Contrast studies may detect new lesion activity and assist in excluding alternative diagnosis. Lesions tend to be ovoid with a major axis perpendicular to the ventricular surface. This is known as dozen fingers. In patients with demyelinating lesions and vascular lesions, the distribution of the white matter changes is important. So patients with vascular pathology involve many times the basal ganglia. They can involve the temporal lobes in the case of CADASIL. They can involve the periventricular areas as the case of patients with CADASIL. And they spare the U fibers and the cortical structures. In patients with demyelinating lesions, it's very common that affect or involve the corpus callosum, the U fibers, the infratentorial region. Temporal lobe can be involved in patients with MS too, periventricular and spinal cord. It's important to notice that gadolinium enhancement lesion is seen in patients with demyelinating lesions and not patients with vascular pathology. Other entity to mention in the differential is progressive multifocal leukoencephalopathy. It's a reactivation of the JC virus systemically in immunosuppressed patients. Multiple foci of demyelination is found initially, sparsely distributed in subcortical white matter, but also involving the cortex and deep gray structures, frequently bilateral and multiple with involvement of the subcortical U fibers. In our experience at Loyola University, so the objectives of our study is to describe the earliest clinical manifestations and diagnostic pitfalls among patients with CADASIL evaluated in the Loyola University. So we retrospectively review medical records of 25 patients with CADASIL that have been evaluated and followed at the stroke outpatient clinic by Dr. Biller and the vascular neurology fellow since 2008. So we have 17 women, mean age of 50, and 8 men, mean age of 51. The earliest clinical manifestation and then were migraines with or without aura in 44% of our patients. Approximately half of our patients have either transient ischemic attacks or subcortical ischemic stroke. None had territorial infarctions or received intravenous tissue plasminogen activator, TPA. 2 patients had epileptic seizures in the history. Talking about the imaging findings, the symmetric involvement of the anterior pole of the temporal lobes on T2 or flare sequence in the MRI was present in 76% of our patients. 1 patient had an intercerebral hemorrhage, and the misdiagnosis occurred in 7 patients. In this pictogram, you have our population. So 5 of them were diagnosed with multiple sclerosis. 1 of them was diagnosed with herpes simple virus encephalitis, and 1 of them with cerebral amyloid angiopathy. MS was the most frequent diagnosis, 5 of 25, prior to the confirmation, either by genetic testing or skin biopsy for granular osmophilic material in the electron microscopy. 1 patient was misdiagnosed with herpes simple virus encephalitis and another with cerebral amyloid angiopathy. On average, our patients have a delay of 10 years from symptom onset until a final diagnosis of CADASIL was reached. In this table, I want to emphasize the difference that the clinical presentations in patients with demyelinating condition as multiple sclerosis and CADASIL. So it's very relevant to talk about the family history in our patients. So CADASIL patients, many times you find family history of migraines with aura or stroke at young age, cognitive impairment at young age, and dementia. MS patients can have or not a family history of a demyelinating disease. Migraine with aura is common in patients with CADASIL. Temporal lobes and external capsule lesions or involvement of those structures are common in CADASIL. The temporal lobe involvement can be seen in patients with MS, but in this case, the clinical presentation is the predominant feature when you make the diagnosis. Spinal cord lesions are associated with MS, and the symmetric widespread lesion is more common seen in CADASIL. So it's important at this point. So I do believe that usually the white matter disease in young population triggers concern of demyelination, but the presence of the key imaging findings and the family history of dementia, stroke, migraines definitely improve the accuracy of the diagnosis when you are seeing patients with CADASIL. Then you have diagnostic tests, including the genetic test, sensitivity 95% with a specificity of 100%, and the skin biopsy that includes the electron microscopy is 100% specificity, but unfortunately the sensitivity is around 57%. Going to the management of a patient with CADASIL, so there is no proven therapy to influence in the natural evolution of CADASIL. So aspirin has been used for stroke prevention in these populations. Management of headache, cognitive, mood, and psychiatric disturbance is relevant. So treatments are not recommended. Ergot derivatives are not recommended in those patients, as can trigger vasospasm. Cholinesterase inhibitors can work in the cognitive impairment, memantine and SSRI2. Counseling and support and rehab is also important in this population and is part of the multidisciplinary approach that we have in our clinics those days. Some pharmacological agents include the L-arginine that may improve endothelial dysfunction, acetazolamide that improves cerebral hemodynamics and is also used in patients with migraines and CADASIL. Donepezil may improve the executive dysfunction, and the short-term statins have not been proven to delay the progression of the CADASIL. So finally, I want to give you this 10 take-home message today. So about CADASIL. So our lecture is given to neurologists, clinicians, general practitioners, residents, fellows, medical students, patients, and family members of patients with CADASIL. So the most common cause of monogenic small vessel disease of the cerebral central nervous system is CADASIL. Is the most common cause of the hereditary subcortical vascular dementia. So the molecular genetic testing Notch3 gene on the chromosome 19 is essential for the diagnosis. So the skin biopsy is an alternative with the Notch3 protein in the vessel walls. The earliest clinical manifestation include migraine with aura that can be most of the time visual aura, protracted aura. So we should avoid the catheter cerebral angiography in those patients as can trigger CADASIL coma. Avoid oral anticoagulants, triptans, and ergot derivative. Analgesic, NSAID, acetazolamide, migraines is essential for treatment. Donepezil may improve the speech processing and executive dysfunction, and psychological support for patient and family and other caregivers is essential in the management of those patients. Well, thank you so much for attending our webinar on CADASIL, and I'm ready if someone has questions about our presentation or a question about CADASIL in general.
Thank you, Dr. Ortiz Garcia, for this educational presentation and for all the work you have done at CADASIL. Our first question is, what care do you recommend for patients to slow the progression of the disease? And what are your thoughts on the use of L-arginine?
Regarding the L-arginine, so has been described that the L-arginine enhance the vasoreactivity in CADASIL patients. So vasoreactivity induced by L-arginine, which is the substrate for endothelial nitric oxide synthetase, is a parameter of endothelial dysfunction that has been shown in those patients with CADASIL. So there was a few years ago, there was a study with ultrasound, transcranial Doppler to measure the vasoreactivity in patients with CADASIL taking L-arginine, and the authors suggest that enhancing vasodilation with L-arginine may be a possible therapeutic approach for CADASIL. So, and also there's a few papers that show that delay the progression of the abnormalities in patients with CADASIL. But there is a limiting factor sometimes in patients taking L-arginine, so that some patients can experience headache, and is the side effect associated with this medication.
Thank you. Patients wonder if there is value in regularly seeing a neurologist or seeing one when they are having a migraine or TIA. Can you comment on when a CADASIL patient should be seen by a neurologist?
Based on our experience, so patients with CADASIL should be seen regularly in the clinic by the primary care physicians or the neurologist. So in Loyola University, they were seen at least once a year by the neurologist in the short clinic. They should advise other physicians or healthcare providers about their diagnosis in case of further interventions. They should know the medication that they are taking to avoid complications. So it's pretty common that we got calls from other healthcare providers or physicians that have encountered with patients with CADASIL, and they are asking about the treatment or what medication we should avoid. So, for example, patients that require anesthesia for surgical procedures, so we recommend avoid cessation of aspirin preoperatively. So try to keep aspirin on board to avoid recurrent ischemic stroke. So measure electrolytes preoperatively, particularly in patients that are receiving acetazolamide, maintain the normal bulimia and the mean arterial blood pressure within the range of cerebral autoregulation, maintains the normal capnia, avoid the head down position as much as possible, as can affect the cerebral autoregulation. So an anesthetic can decrease the cerebral metabolism as well. So it's something that potentially we talk with other healthcare providers when we're taking care of patients with CADASIL. So my recommendation is that those patients should be seen regularly by a neurologist, and at least once a year. Of course, when they experience symptoms, transient neurological deficit, or they experience worsening migraines, or they experience transient TIA or recurrent strokes, they should be also seen by the neurologists.
Thank you. In your experience in patients diagnosed with CADASIL presenting with stroke-like symptoms within the window for treatment for the intravenous TPA or alteplase, is the IV TPA contradicted in these cases?
Is a very good question, an important question in the vascular neurology community. So there is a slight evidence against the use of IV TPA for CADASIL patients. So when they present with stroke-like symptoms within the window for treatment. So you can argue here that, first of all, the NINDS trial, the trial of TPA in the 1990s, they didn't identify patients with CADASIL. So then also has been suggested that some patients who are undiagnosed have been treated with IV TPA with favorable results, but unfortunately they have not been reported. So further studies and a large clinical trials could be beneficial in those cases to know if the IV TPA is indicated or not. So there are recent meta-analysis that evaluate the burden of cerebral microbleeds. So cerebral microbleeds are common in patients with CADASIL. So then the decision to give TPA can be based on the cerebral microbleed burden and the pre-treatment MRI. So many of these patients already have an MRI. So the neurologist on call can take a look at MRI and see what is the number of cerebral microbleeds. The suggested number is that more than 10 microbleeds can increase the risk of bleeding post-thrombolysis. So those findings are consistent in patients with CADASIL and no CADASIL. So I think that at the end, so we should evaluate case by case. So if that IVTPA is going to be beneficial for those patients.
Yeah. Thank you for that very informed answer. You show that MS is the most common misdiagnosis at the institution where the study was conducted. Is it known if this is true throughout the United States?
Well, our observations are not unique to our institution. Those there are a series of patients where the myelinating disorder were the most common diagnosis in patients with CADASIL prior to be diagnosed with CADASIL. So in general, 7 to 10 years was the average of time also to achieve the diagnosis of CADASIL. So at the same as I mentioned earlier, so I believe that the white matter disease in young population triggered immediately the concern of the myelinating lesions, particularly multiple sclerosis. But the clinical presentation with migraines, recurrent stroke, executive dysfunction, cognitive impairment, and the family history that should be considered when you make the diagnosis and you decide the treatment. So the way I was trained, we say that we should treat patients and not just the imaging studies. So the imaging studies are ancillary tests that help in the diagnosis, but it's the clinical presentation and the physical examination that should orient your diagnosis and treatment.
Well, thank you very much for a very informative presentation and also a lot of information in your answers to people's questions.
No, thank you so much again to cureCADASIL Association for inviting me to present our research project from Loyola. I will be happy if you have more questions, if you can send me by email, and I can respond later to all those questions.
Thank you very much. And for those who are listening to the presentation, we at cureCADASIL will make the effort to forward questions on to our speakers. So thank you for being open to that, Dr. Ortiz Garcia. So we hope our audience can join us at our next webinar on February 12th, entitled Harnessing the Power of the Immune System to Develop Therapies for CADASIL. Dr. Joe Abeleda Velasquez, a CADASIL researcher, will be presenting his work focused on the development of therapeutics and biomarkers for CADASIL. And give you something to look at here. Our goal is to connect the CADASIL community, so please contact curecadasil@gmail.com if you would like more information from our speakers or if you have a topic of interest. We also have requests for volunteer opportunities and what are the needs of cureCADASIL Association, and you can contact us to inquire about volunteer opportunities as well as what other needs we have. Recording of today's webinar will be available at our website. Thank you to today's speakers for their work supporting and advancing understanding of CADASIL and for taking the time to share their work with us. Thank you for your audience participation, and this is the conclusion of our webinar.